Sir, can we share our presentation by ourselves?
Hi, can you tell me your catch ID and name, please?
Dr. Lemis Casey,
Okay, hi,
113.
Dr. Lamis. So we already have your presentation here. We will be sharing the screen and we'll give you control. Is that okay?
Can we share our screen by ourselves?
Okay, fine then. Sure, go ahead.
Okay, thank you.
Adesso che sarebbe di nuovo alla foto. ಅಲ್ಲಿ ಹೇಳಿ ಇದಕ್ಕೈತೆ ಅಂತ ಹೇಳಿ ಹೇಳ್ದ ಕನ್ಫರ್ಮ್ ಮಾಡ್ಕೊಂತೀಯ ಅಂದ್ರೆ ಅದನ್ನೇ ನೋಡಿ ಹೇಳ್ತಿರೋದು ಅಂತ ಅನ್ಸತಿ ಫಸ್ಟ್ ಜನ ಇದು
ವಿಡಿಯೋ ಇಲ್ಲ ಆಫ್ ಇದೆ ಮ್ಯೂಟ್ ಮಾಡ್ಲಾ ಇದು ಮ್ಯೂಟ್ ಮಾಡ್ಲಾ
ಅಂದ್ರೆ ಮಾಡಿಸ್ಬಿಟ್ಟು ಹೋಗಿ ಅಲ್ಲೇ ಮಾಡ್ಬೇಕು. ಚಾರ್ಜ್ ಮಾಡ್ಕೊಂಡು ಬರಲು ನನಗೆ ಅದಿಲ್ಲ ಬಾರಿ ಕಷ್ಟ ಆಯ್ತದೆ. ಅದನ್ನ ನೋಡು ನೀರು ತರಬೇಕು. ಬೇಗ ನೋಡ, ಇಲ್ಲರ ಕಷ್ಟ ಆಯ್ತದೆ.
Hello, we'll just call out all the participants to make sure you're all here. Dr. Lamis, CAT ID 113, are you here?
Yes, madam. Yes, madam.
Dr. Bhuvana Chandran, CAT ID 124, are you here? Your audio is not clear.
Yes, yes. Is it clear now?
Yes,
Yes.
yes. Dr. Anita, CAT ID 126. Dr. Anita, Dr. Anita, can you? Dr. Pradeep Kumar, CAT.
Yes, ma'am.
Yeah, okay. Dr.
Hello.
Sahana Shri. Yes, Dr. Pradeep.
Can you hear me?
Dr.
Can you hear
Sahana
me?
Shri. Yes, you're audible.
Break up.
Okay. Fine.
Voice is breaking, madam.
All voice. Dr. Sahana Shri, catch ID 139. Dr. Vinay Kumar, catch ID 140. They're not here. Thank you.
ಇಲ್ಲ
We shall be starting with our session now. Good afternoon to everyone present here. Welcome to the 37th Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College, Bangalore. The theme for this year is very interesting, redefining public and beyond. With this, we shall begin with our first session presentation, postgraduates. Let us take this opportunity to introduce our esteemed judges for today. Dr. Twinkle Agarwal, Associate Professor, St. John's Medical College, Bangalore, and Dr. Harish, Professor and Head, Mandya Institute of Medical Sciences, Mandya. We are very, very thankful that you have taken your time off to judge this session, and we hope this will be a very amazing session for all the participants as well as us, your mod Deepti, and we are UG students of Ramaya Medical College. So let us go through the instructions for today's session. Participants, kindly mute yourself. moment. The most important instruction is participants kindly stick to your time limit, which is 6 minutes for presentation and 2 minutes for question answers with the judges. We, the moderators, will be intimating you 1 minute prior to the end of your time, that is at 5 minutes. So moving on, let's begin with first participant for today, Dr. Lamis. Dr. Lamis, would you like to share your screen now?
Yes, madam. But I'm not able to share.
Give you the presenter's role. Dr. Lamis, are you able to share your screen now?
No, madam.
At the bottom, you will have an option. Yeah. Please make sure your presentation is in full screen, okay?
Madam, can you share my screen because I'm not able to share?
1 second.
Yes.
Am I audible, madam?
Yes, you can start now.
Good afternoon. My topic is stress among school teachers during COVID-19 pandemic. How to change the slide? Madam, we know that COVID-19 pandemic has adversely affected people all over the world, which was the one main sector which was largely disrupted during this pandemic is the education system. The situation has put forward new perspective into education, a paradigm shift from realistic to a virtual platform. Many educational institutions and teachers are not equipped with digital facilities to cope up with sudden change from traditional education system to virtual
Voice
mode.
break ಆಗ್ತಿದೆ.
Can you share the change the slide, madam?
Voice break ಆಗ್ತಿದೆ.
I'm not able to change the slide, madam. Oh yeah. Online education is a new experience and would have been a real challenge to teachers who have been engaging students in realistic class now. This itself may create ample stress to the teachers in addition to the stress due to health concerns of the family and domestic responsibility. My study aims to throw light on mental challenges of teachers evaluating the stress they are subjected to. The aim and objective of my study is to find assess. Madam, how can we change the slide? It's not changing.
We are very sorry,
Madam?
there is some issue with handing you slides. If you can just tell us next slide, we will move to the next slide for you. Is that okay?
Yeah, next slide. It's not changing actually. Aim and objective of my study is to assess the prevalence of mental stress among teachers handling online classes during COVID-19 pandemic and to find out the risk factors of the mental stresses. Next slide. Materials and methods. I have done a cross-section study among school teachers dealing with primary, high school and high secondary sections during by an online mode during November 1st to November 30. And sample size have been calculated as 173 using the formula 4pq by d square, where p is 30.4 and an absolute error of 7%. I have taken convenient sampling, and mental stress was assessed with the help of perceived stress scale, which consists of 10 scales and a total of 40 score, and a score of 0 to 13 indicate low stresses and 14 to 26 indicate moderate stresses and more than 26 indicate high stress. Actually, the screen is not changing. Madam, and the result of my study. Can I continue the presentation?
Neither.
We have made you the present. Hi, Dr. Lamis. This is Dr. Anand Rao. We have made you the host and we have shared the presenting rights to you. I think you are able to change, isn't it?
But how can I take the content, sir?
We have stopped now.
The problem is that I'm not.
You're not able to share the screen?
No, sir. Now, is it visible, sir? Sir? Is the screen visible, sir?
No, Dr. Lamis. We are trying to share from here because you said you couldn't. We are just trying. Give us
Okay,
1
sir.
minute.
Okay, sir.
Share.
Yes, yes, welcome. Welcome. We can't give short answer. Okay. We can control it. We're not able to.
Dr. Lamis, you can start the presentation.
Okay, sir. How can I change
You
the
start from
slide
the-
also?
No, we will change the slides. As
Okay,
in
sir.
you can start. Your time starts.
Okay, sir. Good afternoon, everyone. My topic is stress among school teachers during COVID-19 pandemic. And we know that, next slide, COVID-19 pandemic has instilled a considerable amount of stress among school teachers. The one main sector which was largely disrupted during this pandemic is the education system. The situation has put forward new perspective into education, a paradigm shift from realistic to a virtual platform. Many education institutions and teachers are not equipped with the digital facilities to cope up with sudden change from traditional education system to virtual mode. Next slide. Online education is a new experience and would have been a real challenge to teachers who have been engaging students in realistic classes till now. And this itself may create ample stresses to the teachers in addition to the stress due to health concerns of the family and domestic responsibilities. And I have done a study my aim is to throw light on mental challenges of teachers evaluating the stresses they are subjected to. Next slide. Aim and objective of my study is to assess the prevalence of mental stress among teachers handling online classes during COVID-19 pandemic and to find out the risk factors of the mental stresses. Next slide. And I have done a cross-section study by online mode from November 1st to November 30 among the school teachers dealing with primary, high school and higher secondary sections. I have calculated sample size as 173 using the formula 4PQ by D square, where P is taken as 30.4 from previous study and an absolute error of 7%. Convenient sampling was taken and mental stress was assessed with the help of perceived stress scale, which consists of 10 questions. And a scale of 0 to 13 indicate low stress, a scale of 14 to 26 indicate moderate stress, and more than 26 indicate high stress. Next slide. And this shows the result of my study, and this is the baseline characteristics of study participants. I have collected data from 199 teachers. Of that, majority of them belong to the age group of 41 to 45 years. And among the 199 participants, 76.88 were females. And I have collected data from teachers of state government, central government, aided and private school. And 69.3% of the teachers were teaching in the higher secondary school, and 86.4% doesn't have a prior experience on online teaching. Next slide. This figure shows the that 90% of the teachers used to take the live classes, and hours of online classes, majority of the teachers used to take within 1 to 2 hours of online classes, and 76.4% of teachers tells that their interaction with students were deteriorating, and 84.9% tells that their class preparation time has increased during these online classes. Next slide. And this figure shows the perceived stress among the teachers, and 76.4% of the teachers were suffering from moderate amount of stress, and 8.5% of teachers were suffering from high stress. And this table shows the association of stress with various factors, and we can see that there is a significant association of stress with lack of interaction with students during online classes, as well as prolonged screen time. And there is no significant association between previous experience of online teaching as well as section of class taking and gender. And my conclusion is that 76.4% of teachers are suffering from moderate amount of stress. The main reason for stress was found to be the emotional aspect of deterioration in communication of teachers with their students and health issues related to prolonged screen time. So I recommended there should be an adequate training should be given to the teachers on how to take an online teaching and avoid continuous teaching and ensure adequate breaks in between. And give more importance should be given to the interactive session. There should be some 0 hours so that teachers can communicate with the students. And these are my references. Thank you.
Thank you, Dr. Lameez.
Thank you.
We will move on to our next. We will move on to our question answer session now, which is for 2 minutes. Over to you, judges, Dr. Harish and Dr. Twinkle Agarwal.
Yeah, good afternoon. This is Dr. Twinkle here.
Good afternoon, ma'am.
Good afternoon. Well done, Ramesh. Unfortunately, I think since you were the first participant, you had a few challenges.
Madam.
Hope you didn't have a lot of stress due to the presentation.
No, madam.
Lamis, I want to ask you, did you come across, after you have done a good extensive review of literature, so did you come across previous studies on stress among school teachers in non-COVID times?
Non-COVID time, I have come across a study during non-COVID time, not during the COVID times.
Yeah. So what
There
was the
was
level
a-
of stress you found in that?
There was a high perceived stress among teachers. A study in previous studies.
Yeah. What was the stress level?
In a study in Israel, they shows that about 80% of the teachers have high stresses.
So how is that different? You found 70%. So that looks less than now, no?
Yes, madam.
Okay, over to you, doctor.
Dr. Lamis.
Yes, sir.
Good afternoon. It was a nice presentation.
Good
During
afternoon,
this
sir. Thank
difficult times, you have taken sufficient pain and made efforts to do the study and present it. Congratulations first.
Thank you, sir.
My question is, in your conclusion, you have said the stress levels are partly due to health effects because of prolonged screen time among
Yes, sir.
the
Because
teachers. But you have not mentioned anything about the health effects leading to stress because of prolonged screen time in your study. Have you done anything?
I have asked them whether prolonged screen time has increased the stress. They told us it's like
No. You say your conclusion. I agree with what you are
health
saying.
issue.
But your conclusion says about health issues. But I don't recall you talking about anything
No, sir. I
regarding.
haven't find out any health issues.
So what is not done should not be projected. Okay.
Okay, sir. Okay,
It's
sir.
all right. It's all. Don't worry. But it was
Okay,
a nice
sir.
presentation. Congratulations once again.
Thank you, sir.
Okay. Thank you.
Thank you, sir.
Lamis, can
Thank
I
you,
ask you one more
judges.
question? How did you contact the teachers, Lamis?
Online through Google Forms. I have contacted principals of certain schools and given the Google Forms, asked them to circulate among other teachers.
Okay. Just for the future, Lamis, make sure you tell the methodology in great detail about how you have done it.
Okay, madam.
Okay, Lamis.
Okay. Thank you, madam.
Thank you.
If we're done with the questions, we can move to the next participant.
Yeah. Yes, please.
Yes, please.
Okay. The next participant is Dr. Bhuvana Chandran. Catch ID 124.
Hi, ma'am. Hi. I can't able to share the screen. Can you please? Hello. Is it audible?
Yes, yes. Is it? Are you able to see your PPT?
Yeah, ma'am, I can able to see. Yeah, ma'am. Shall I start?
Yes, you can start.
Yeah. Morning. Good afternoon, all. Today my topic is, which I'm presenting, is assessment of sleep pattern during COVID-19 pandemic cross-sectional study, and I am from the second year postgraduate student from the department of Bajwesha Medical Hospital. Can you go on to the next slide? Next slide, please.
Yes, I'm the introduction slide.
Yeah, first we start with the introduction. Here, sleep is a physiological process which highly depends on the environmental and the social and varies substantially with the level of stress. The spread of COVID-19 virus in India, especially, which leads to spend maximum time indoors to prevent from infections. Sleep quality has degraded during isolation, also due to the disturbed sleep phase cycles and also the light exposure. The pandemic has affected sleep, hence the study was conducted to assess the sleep pattern during the COVID-19 pandemic. Next slide, please. So, yeah, okay. And the objective is to assess the sleep pattern during the COVID-19 pandemic and to assess the sleep during the COVID-19 pandemic. Madam, next slide, please. Yeah. Materials and methods. Yeah. Here we are in the cross-section study. Sorry, materials and methods. And materials and methods. Type of study is a cross-section study here. Type of study is a cross-section. Yeah. The type of study is done in our urban healthcare center in Chitradurga. Because of the convention, the sample is 196. The study was for 3 months from June to September 2020. And the data was compiled and analyzed using the SPSS software S20. Next slide. Results. Here 40.3% of the participants no changes in the sleep pattern due to the long working hours, and almost 45% of the participants have practiced 6 to 7 hours of sleep before the COVID-19, when it was decreased during the COVID-19 pandemic. The 70.9% of the study population shows that there was no changes in the quality of sleep during the COVID-19 pandemic. Next slide. So during the COVID-19 pandemic, the association between the gender and the change of sleep shows that out of 99 male participants, 23 has 20% improved the quality of sleep, and 76% of the people had no changes in the quality of sleep. Then out of 97 female participants, there are no changes in the quality of sleep, and 26% had quality of sleep very much worsened. The association which is found between the male participant and female participant between the quality of sleep shows the statistically significant p-value with less than 0.05, and the number of sleep hours received during and before the COVID-19 pandemic shows that there is a significant association between the number of sleeping hours affected the study participant before and also during the COVID-19 pandemic, which also the statistically significant p-value of less than 0.05. So coming to the conclusion, the study indicated that the half of the study population had changes in the sleep pattern, and there was a very minimum change seen in the sleep quality during the pandemic, which is compared to before the pandemic. So the main recommendation here is public awareness regarding the importance of good sleep and quality to maintain the physical and mental health during the COVID-19 pandemic. And these are my references. And these are my references. Thank you.
Over to you, judges.
Yeah, good afternoon, Dr. Bhuvanan. This is Dr.
Yeah, good afternoon, madam.
Yeah, good relevant study. I want to know what is the questionnaire or interview schedule which you used for the study?
Hours of it depends upon the hours of sleep and quality of sleep, like when the person is worried or not.
Did you use any standardized questionnaire?
No, it's a pre-defined questionnaire, madam.
Okay, did you validate it?
Yeah, no, sorry, ma'am, it's not validated.
Okay, and how did you interview the patients?
So self-interaction only, ma'am, in the urban healthcare center.
That is, patients were visiting the urban healthcare center?
Patient visiting the urban.
Okay. Dr. Harish?
Okay. Dr. Bhuvanachandran.
Yes, sir. Good afternoon, sir.
Adding to the first question Madam asked, you said it was a pre-tested questionnaire. Where did you test the questionnaire? Where did
Sir,
you
by
do
the pilot study, sir.
Where did you do the pilot study?
In the
Where
urban
did
field
you
practice
do
area
the
of
Chitradurga? What
sir?
was in the urban field practice area of Chitradurga?
Chitradurga, sir. Yes, sir.
Okay, the pro forma was based on any other sleep quality index questionnaires?
No, sir. No.
No, okay. You designed it yourself and you administered it. In which language was the questionnaire?
It is in Kannada only, sir.
In Kannada only. You're fluent in Kannada?
Yes,
Comfortable
sir.
in
Fine.
Kannada?
Yes.
You can read. You can read and write.
Yes, sir. I can read in Kannada, sir.
Okay, fine. Now, how did you arrive at the sample size?
Sir, actually, it was a convenient sampling. The people who visited from the last
No.
3 months, from June to September.
Sample is convenient. Sample is convenient sampling.
Okay, sir.
But how did you arrive at the sample size? How did you arrive at the sample size?
Actually, sir.
Did you use any formula to arrive at the sample size? Any previous
No,
studies
sir.
regarding sleep deprivation in COVID situation? You came across any literature?
So people visiting the
Okay.
urban center for the 3 months and who are
Okay.
concerned, only they are included, sir.
No, there are only few people.
Ready to give the consent for the studies, sir.
Yeah, you are asking only questions. No, you are not doing something else, and they are not ready to give consent. Okay, fine. In your results,
Yes, sir.
you say
sir.
that some males actually had an improved quality of sleep, whereas females, they have said that they have had their quality of sleep has been disturbed due to corona.
Because here, in my study, yes, sir, I got it, sir. So here, more of them are actually home, like housewives, sir. So that was the problem that there is no change. So
the males, if there is a pandemic, they rest comfortably, but the females are worried. That's what you are trying to tell us. Only the females are worried.
Not worried, sir. There is no change in the quality of sleep in females. But
No.
males, they are getting regular patterns. Like instead of visiting the outside, and they don't need to roam here and there. So they felt like it was improved quality of sleep.
Okay, doctor. Thank you. It was a nice presentation. Thank you very much.
Thank you, sir.
Yeah. Thank you, Harish.
If there are no further questions,
Thank you,
we
sir.
can move on to the next presentation. Dr. Anita, catch ID 126.
Hello, madam. I'm here. Can you
Would
able
you like
to
to
hear
share
me,
your
madam?
own screen? Yes. you're
I'll try,
audible.
madam. I'll try. Can I able to see the screen, madam?
Yes, we are able to see it. Could you make it full
Can
screen?
Okay, madam. Can I start my study?
Yes, you can start.
Good afternoon, everyone. Mine is a comparative study of utilization of ABRK, that is Ayushman Bharat Arogya Karnataka scheme in tertiary care teaching hospital before and after COVID-19. The authors are myself, Anita BP, postgraduate student in SIMS, and Dr. Praveen Kumar N, Professor and HOD of SIMS, Dr. Swati HN, Assistant Professor of SIMS. Introduction. Coming to introduction, Arogya Karnataka was started on 2nd March 2018 by Government of Karnataka. Then the Government of India later introduced Ayushman Bharat. Since the goals and objectives were same of both the schemes, they merged both the schemes and called it as Ayushman Bharat Arogya Karnataka, which was implemented on 30th October 2018. enrolled beneficiaries will get a sum of 5 lakh per family per annum, and the others who are non-eligible households or RSP are not included will get a rupees of 1.5 lakh per family per annum. Continuation of the introduction, there are 286 hospitals connected to ABRK. Then in Arogya Karnataka enrollment centers, public can register their names and get Arogya Karnataka card. The public has to produce their Aadhaar card. The need for the study was that, keeping above factors in mind, the study was conducted to know whether there was increase or decrease in the utilization of ABRK services in non-COVID patients during COVID-19. Objectives and methodology. Objective was to know the difference in utilization of ABRK scheme before and during COVID-19. Methodology. A comparative study was done from October to November 2020 to know the utilization of ABRK services in second quarter, that is in April, May and June of 2019 to that of the 2020 in the same months. The permission was taken from Dean and Director of SIMS and Medical Superintendent of Megan Hospital, Shumaga, to conduct the study. The data required was for the study was collected from ABRK Megan Hospital, Shumaga. Data was collected from the records recording the number of patients utilizing the ABRK services and patient-specific details like BPL and APR card holders, number of males and females using the services to which specialty they were referred to. Data was analyzed manually and chi-square test was applied to know the significant difference. In my study, and that in the results, in this table, we can see that the ABRK utilizers were more during 2020 April, May, June compared to 2019, and it was statistically significant. The others like APL and BPL card holders were more, and in number of males utilizing the ABRK scheme was more, but it was not statistically significant. This is a multiple bar diagram showing the utilization of ABRK facilities. It shows that ABRK facilities was utilized more during the 2020 during April, May and June season. It is the major referrals. About 20 departments were referred, departmental cases were referred. Among them, majority was in cardiology. In 2019 was cardiology in April and June, and it was in neurology in May season. In 2020, most were referred in the medicine in April, orthopedic in May, and oncology in June season. Coming to conclusion and references, conclusion, ABRK helped most of patients in availing healthcare facilities from the private hospitals even during COVID-19 times. So such schemes are recommended in developing countries like India. Hello, madam. And these are my references. Thank you.
Dr. Harish?
Anita, madam.
Yeah, I know. Dr. Harish, you can go first, Dr. Harish.
Dr. Anita?
Yes, sir. Good afternoon, sir.
Can you go to the slide? Can you show the slide number 4 that has the statistics?
Okay, sir.
Not the pie chart. Before that,
Okay,
you
sir.
had statistics. Can you display it?
Yes, sir.
Hosts, can you kindly display it?
Pardon, sir?
Yes,
I'm
sir.
asking.
We've given her the control again.
Okay,
Dr. Anita, you can share it now.
Sir, I have put the statistic part, sir.
Have you shared your screen, Dr.
You have to
Anita?
share the screen.
I have shared, sir. In mine,
Where?
it is coming, sir.
We cannot see it.
In mine, it is shared, sir. Now, can you see it, madam?
No, Anita.
Mine, it is showing, madam.
Just do it
Okay.
again.
Uh,
No, the next slide, next slide. Move. Your results slide, the first slide. Results is slide number 6. Slide number 6. Okay. Oh, no, go back. Okay. So, except the difference between ABRK utilizers and not utilizers during the
Able to
COVID
hear
period,
you.
you are not.
Hello.
You're not. My audio is. Hello.
Hello.
Can you hear me now? Dr. Anita? Can you hear me?
Yes,
Hello?
sir. I'm able. Yes, sir.
You are able
Hello,
to hear
sir.
me?
I can hear you.
Okay.
Yes, sir.
Except for the first ABRK utilizers and non-utilizers, the difference
Hello.
between. You said you are able to
Hello.
hear me. Hello. Yes, I
Yes,
Hello.
sir.
unmuted.
Sir, we are able to hear you. I
Hello.
think there's a problem with Dr. Anita's internet.
Hello.
Dr. Anita, are we audible?
I'm not able to hear you, sir.
Dr. Anita, can you hear me?
Hello.
Can you hear me?
Hello.
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 There must be a problem with her internet
No, I
connection.
can hear her. I can also hear her
Hello.
loud and clear.
Sir.
Hello, sir.
Dr. Anita,
Hello.
have you muted me?
Hello.
No. Okay.
Now I'm not able to
No,
hear
sir.
you, sir. Voice is breaking, sir.
We are able to hear
Voice
you,
is
sir.
breaking, sir.
Okay.
Hello.
Okay, madam. What you can do, the hosts
Hello.
can ask madam to ask a question. Hopefully,
Hello, sir.
she may be able to connect. Okay, kindly ask her.
Hello. Voice is breaking, sir.
Anita, can you hear me? Dr. Anita?
Hello.
Yeah, Dr. Anita, can you hear me?
Hello.
I think host, I don't think she can
Hello.
hear. Hello?
We can
Hello.
ask her to come back later.
Hello, sir.
After everything is
Sir, voice
okay.
is breaking, sir.
Okay. I think we'll move to the next one.
Okay.
Hello. 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 Now I'm able to hear, madam.
Okay, madam, I asked you that slide, except
Yes, sir.
the difference between COVID and ABRK and non-ABRK people, there was no other difference. Okay. Yes.
No, sir. APL and BPL holders and number of females and males, sir.
Males
These
remained
were
the
the
same.
differences.
There was no statistically significant difference. Okay, madam.
Yes,
Thank
sir.
you. Thank
Yes,
you.
sir.
That's all.
Thank you.
Dr.
Thank you,
Twinkle.
sir.
Okay.
Thank you, sir.
Yeah. Thank you, Dr. Harish. Dr. Anita? Dr. Anita? Dr. Anita, can you hear me?
Madam.
Yeah. Dr. Anita,
Hello.
relevant study. Yeah, this
Yes,
study was done in your hospital, Dr. Anita?
Yes, madam.
Okay, so this was a record review.
Yes, madam. It was a record review.
Okay, and all these patients are from your records?
Yes, madam. From the record which they have given, I have taken from those records and I have put the numbers, madam, who had utilized.
Okay, and can you just explain what non-utilizers mean? They didn't use the
Non-utilizer. Madam, ABRK facilities is for the inpatients, madam. The non-utilizers were how many inpatients came. Among them, who used the ABRK utilizers were 344. For example, in 2009 April, and 344 were the users. Among the total the total amount of incomers were the utilizers, who were inpatients were 5,798 plus 344 were the inpatients. Among them, 345 were the utilizers and non-utilizers were 5,798, madam.
Okay, Dr. Anita, do you have any COVID-related data for this?
No, madam, I don't have COVID related. I have taken in non-COVID patients, madam.
Okay.
who are referred and the non-COVID patients.
Okay. Thank you, Anna.
Thank you, madam.
Start.
We can move on to the next participant, I think.
Yes, can you hear me?
Yes, Dr. Pradeep.
Can you see my slides?
Yeah, no, we can see your slides. We can't.
Is it visible now?
No, we cannot see your slides till.
Yeah.
Yeah, now it's visible.
Okay. Let's start now.
Yes, please start.
Okay. I'm Dr. Pradeep, first year postgraduate from Department of Community Medicine, BMCRA. I'm presenting a cross-sectional study to assess knowledge regarding infection prevention and control guidelines during COVID-19 pandemic among the healthcare workers in tertiary care hospital in Bengaluru, Karnataka. Introduction: COVID-19 infection is caused by the novel severe acute respiratory syndrome coronavirus 2, that is SARS-CoV-2. This study depicts the need for the control of hospital-acquired infection to contain the pandemic and also the safety of the healthcare professionals in the hospital premises. COVID-19 infection prevention and control, that's IPC guidelines, have been developed and adopted based on the knowledge gained from the experience during the past MERS and SARS-CoV in the past 20 years. Objective is to assess knowledge about IPC guidelines during COVID-19 pandemic among the healthcare workers, mainly doctors and nurses. Materials and methods. It was a cross-section study done from November 29 to December 12th in Victoria Hospital, Bengaluru, among doctors who did COVID duties. It was a self-administered questionnaire, questionnaire used via Google Forms. The sample size was calculated by using the cross-sectional study formula, that is N is equal to 4 PQ by D square. The prevalence was taken as per the article by Amani SP et al., that is 0.693. Sample size was 85. By adding 10% attrition, final sample size was 100. Methodology was a questionnaire was developed, it was pilot tested, and a list of healthcare workers in Victoria Hospital was prepared. By using simple random sampling, 100 healthcare workers were contacted via telephonic call. They were explained the purpose of the study and their verbal consent was taken, of whom 98 gave the consent. And then the Google form questionnaire was sent via WhatsApp to the subjects. Out of this, 90 completed the questionnaire. Statistical analysis was done using SPS version 20. These are my results. Among the 90 respondents, 62 were doctors and remaining 28 were nurses. The age group of all participants were between 18 to 39 years. Figure 1 shows the distribution of study participants based on gender. That is, among the doctors, 58% were females and 41% were males. Among the nurses, 25% were females and 75% were males. Figure 2 shows the mean age in years. That is, among doctors and nurses. Among the doctors, the mean age was 28.7, and among the nurses, it was 33.9. This table shows the distribution of study participants based on their knowledge about WHO IPC guidelines, that is standard operating procedure. Knowledge questions were prepared. Knowledge questions was given via Google form. These are the topics I took. Like many questions were shared about these topics, and I took it shows the correct response of doctors and nurses, and the red color, the p-value which is mentioned in the red color, it shows the statistically significant results about these topics. First one is about whether they have undergone training regarding IPC. Like 96% doctors and 82% doctors said yes. Regarding hand hygiene, knowledge about hand hygiene, 82% of doctors and 53% of nurses gave correct answers. Regarding respiratory hygiene, 82% of doctors and 64% nurses gave correct response. Regarding personal protection equipment, it's PP, that is regarding donning, doffing, and principles of usage, 91% doctors and 78% nurses give correct response. Regarding steps of safe injections, 96% doctors, 89% nurses give correct response. Regarding triage, 85%.
Hello, we can't hear you. Dr. Pradeep? Hello?
Dr. Twinkle, ma'am, are you able to hear us?
Yeah, we can. I can hear you.
Dr. Pradeep, are you here? We are not able to hear you.
Can't hear Dr. Pradeep. Hello?
One. Presenter, we are unable to hear you. Looks like it looks like that if we can, we don't have a presenter in this session. Harish sir, the presentation,
Yes, yes, tell me.
the session,
Tell me. Yeah. I think we can give him another chance later on if he can become audible. You can move on to the next participant, I think. Kindly consult Dr. Twinkle also. If she agrees, we can move on to the next participant.
Yeah, sure, Dr. Harish. I think we can move on to the next participant. If Dr. Pradeep gets connectivity, we'll get back to him.
Yeah.
Judges,
Yes.
that was the last participant of this session.
Oh, the other two are not participating.
No, the last two participants, Dr. Sahana Shri and Dr. Vinay Kumar, have dropped out, so they won't be participating for today.
Okay, madam. Okay, we have got only three. Only
Shall we
you try to connect to him because he should not lose out.
Yes, sir.
Try to connect. If you have got his phone number, kindly call him over the phone.
He's connected. Okay, Dr. Pradeep Kumar is back online.
Okay. Can he? Hello. ಏನಾಗಿತ್ತಪ್ಪ ಪ್ರದೀಪ?
Sir, network.
ಪ್ರದೀಪ್.
down ಆಗಿದೆ sir.
ಎಲ್ಲ ಇದೆಯಾ ನಿನ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಅಲ್ಲಿ ಇದೆಯಾ ಎಲ್ಲ ಆಚೆ ಇದೆಯಾ ಮನೇಲಿ ಇದೆಯಾ
ಇಲ್ಲ ಸರ್ ಬಿಬಿಎಂಪಿ ಕೋವಿಡ್ ವಾರ್ ಅಲ್ಲಿ ಪೋಸ್ಟಿಂಗ್ ಹಾಕಿದ್ದಾರೆ ಸರ್ ಅಲ್ಲಿಂದ
ಕೋವಿಡ್ ವಾರ್ ರೂಮ್ ಅಲ್ಲಿ ಸರಿ ಕಣ ಅಲ್ಲೇ ನೆಟ್ವರ್ಕ್ ಕಮಾರ ಆಯ್ತು ಮೊದಲಿಂದ ಸ್ಟಾರ್ಟ್ ಮಾಡು ಟಕ ಅಂತ ಫಾಸ್ಟ್ ಆಗಿ
ಓಕೆ ಸರ್
Dr. Pradeep, we have given you control. Please share your screen, okay?
Okay.
ಶೇರ್ ಮಾಡು ಶುರು ಮಾಡು ಫಾಸ್ಟ್ ಆಗಿ.
Can you see my slides?
Yeah, we can see you.
Okay.
Slide. You can skip the introduction slide and start from your
skip it.
Shall I start from like methodology?
Background ಬಿಟ್ಬಿಡು ಇದು materials methods in ಶುರು ಮಾಡು. Start from here.
Sir, it was a cross-section study conducted from November 29 to December 12th in Victoria Hospital, Bengaluru, among the healthcare workers, that is doctors and nurses who did COVID duties. It was a self-administered questionnaire. Self-administered questionnaire was used via Google Forms. The prevalence of right knowledge regarding the IPC guidelines, as per the article, ammonia S beta was taken. It was 0.693. The formula used was n is equal to 4pq by d square. Sample size came to be 85 by adding 10% for attrition. And after rounding off, the final sample size was 100. Methodology used was like questionnaire was developed. It was pilot tested and validated. The list of healthcare workers in Victoria Hospital was prepared. Then by using simple random sampling, 100 healthcare workers were contacted via telephonic call and explained the purpose of the study and taken their verbal consent. Out of this, 90 completed the questionnaire. Statistical analysis was done using SPSS version 20. Results are among 90 respondents, 62 were doctors and rest 28 were nurses. Age group of all participants was between 18 to 39. Figure 1 shows the distribution of study participants based on their gender. Among the doctors, 58% were females and 41% were males. Among the nurses, 25% were females and 70% were doctors. Its mean age is 28.7. Nurses mean age is 33.9. This table shows the distribution of study participants based on their knowledge about the WHO IPC guidelines, that is standard operating procedure. Questionnaire was prepared based on these topics, and right response was taken, and I have taken the percentage of right response between the doctors and nurses, and I have taken the chi-square test, and the p-value was calculated. The red color shows the statistically significant value. Regarding training, 96% doctors and 82% nurses said yes, they have undergone training. Regarding hand hygiene, 82% doctors and 50% nurses gave correct answers. And respiratory, 64% nurses gave correct answers. Regarding personal protective equipment, that is PPE, that is donning, doffing, and principles of usage, 91% doctors and 72% nurses gave correct response. Regarding steps of safe injection, 96% doctors and 89% nurses gave correct response. Regarding triage, 85% doctors and 50% nurses gave correct response. It was statistically significant. Regarding protocol for confirmed COVID-19 patients, 90% doctors and 67% nurses gave right response. Regarding outpatient care, 85% doctors and 71% nurses gave correct response. Regarding types of face mask, uses of face mask management, 96% doctors and 89% nurses gave correct response. And regarding environmental decontamination, that is disinfection of equipments and soil denial from COVID-19 patients, regarding dead body management, 79% doctors and 64% gave correct response. Regarding biomedical waste management and color coding and all, 96% doctors and 70% nurses gave the right response. It was statistically significant. Conclusion was, many of the healthcare professionals had fair knowledge regarding IPC guidelines, but they still more need to be updated regarding this, which is very much needed, as IPC guidelines are very important aspect of pandemic mitigation and control. IPC is key for quality patient care, thus helping them in improving the knowledge and practices in correct direction. These are my references. Thank you.
Dr. Pradeep,
Hello.
Dr. Twinkle here.
Hi, ma'am.
Yeah, good presentation, Dr. Pradeep. Did you use any sampling technique, Dr. Pradeep?
Simple random sampling.
Okay,
simple random
nothing.
sampling using lottery method. Hello.
Yeah, okay. And in the can you just put up the slide which had your table with your p-values?
Yes, ma'am. Yes, ma'am.
Yeah, the first one, can you just explain what that p-value means?
Like how many of doctors and nurses undergone training, like yes or no question type, ma'am. Like 90%,
Yeah. So what?
96% said less, and
Correct. So you
82%
got
of nurses said less.
yeah, you got a significant value. So what does that mean? Pradeep? Hello?
Dr. Pradeep, are you here?
Yes, ma'am.
Yeah, Dr. Pradeep, I wanted you to explain what that significant p value means for any one of them. Yeah. Can you hear me, Dr. Pradeep?
You're breaking, ma'am.
Yeah.
Your
Can you
voice
hear
is
me now?
breaking. Ah, yes, ma'am. Yes, ma'am.
Yeah. Can you just explain any of these significant p values, what they mean? Any one of the ones which are significant.
P-value, like P-value, if it is more than 5, the probability of null hypothesis is true. If P-value is less than or equal to 0.05, then it is statistically significant. That means the test hypothesis is false or should be rejected.
Okay. Okay, Dr. Pradeep. Over to you, Dr. Harish.
Dr. Pradeep, you have said you considered attrition and rounded off the sample size to 100. Is attrition a problem in cross-sectional studies or longitudinal studies? And you have to answer me. Is attrition a problem in cross-sectional studies or longitudinal studies? Hello?
Hello?
Is attrition, can you hear me now?
Hello?
Can you hear me now? Is attrition
Yes,
a problem? Attrition a problem in cross-sectional studies or longitudinal studies?
Cross-sectional studies, sir.
It's a problem in cross-sectional studies and not a longitudinal study. You sure?
Yes, sir.
Okay, Dr. Pradeep. No more questions. No more questions. Nice presentation. You have done a good work.
Okay.
Thank you. Thank you.
Thank you. Thank you.
Okay, with that, we apologize for all the technical glitches that took place. This was the first session, and thank you to all the participants for having stuck with us till the end. COVID-19 has brought a paradigm shift in the way in which we interact with people and have these conferences, and things have been a little glitchy, but we hope to have all things back. Thank you to the judges for taking that time off their busy schedules to come and mentor the session. And thank you to all participants once again. Thank you.
Thank you.
Hello? Hello?
Yes. Yes, sir, Dr. Harish.
Yes.
Madam, how to share the result? Hello? How to share the
You can
result?
get in touch with our so you can get in touch with our community medicine department, sir.
Okay. Okay. Dr.
Sir, I think the document they have sent us, we'll have to enter the marks and send it back on the same email.
Okay,
Yes,
I think
ma'am. Yes,
we'll take a scan of it or scan it and send it. I think that's okay, madam.
Or you can enter it digitally and send it. Yes, ma'am. Yes, sir. Yes.
The form, I don't think we can fill it digitally. Can we fill it digitally, madam?
Yes, sir, it's a Word document. We can fill it, sir.
Okay,
Yes,
then
sir, we have sent
we'll
it by
fill
mail.
it. Okay, madam. I think
Yes, sir. Yes, sir,
we
whatever
will
is.
break and I'll send it tomorrow morning, madam. Is it okay? Dr.
Yes, sir.
Wrinkle.
Okay.
Okay.
Yes, sir.
Okay, madam. Thank you. Thank you.
Thank you so much, sir. Thank you, ma'am.
Bye, bye.
Good afternoon. Can you hear me? Good afternoon. Unmuted.
Yeah, you are audible.
So we went to the 36th level of an association hosted by Ramaya Medical College. The theme was COVID-19. With this, we shall begin with our session oral paper presentation. Let us take this opportunity to introduce our esteemed judges for today. Dr. Manjunath, Professor Community Medicine, Mysore Medical College, Mysore, and Dr. Girish B, Assistant Professor, Community Medicine, Chamarajnagar Institute of Medical Sciences. We are thankful to you for dedicating your precious time to judge this session. We like this. So, would you like presenters before we start the session?
Yeah. So, can I talk? So, welcome to all the presenters. So, today with the COVID-19 pandemic, we are virtually presenting. So, it was good if it was a regular one, but anyhow, we need to go with the time. I wish all the best for all the participants. So, even with this situation, we should be like continuing our research and do with whatever best can be done for the medical field, because if world is is getting to know the importance of the health and whatever the the community medicine in this critical time. I hope this presentations, researches, and will help a small step towards the further any not only COVID, or it could be in any support in the medical field. Okay, all the best for all the presenters.
Thank you.
So,
Good
Dr.
afternoon,
Manjunath.
one and all. Good afternoon, sir, and all the participants and organizers. First of all, I would like to thank CACH organizers for making us the jury for this program. And it's a pleasure to work with Girish sir. And Girish sir has already told the importance of the event, the context of the ongoing pandemic. Without wasting much time, shall we start the presentations, please? Thank you.
Shweta? ಅವ್ರೇನಾದ್ರೂ ಹೇಳಿದ್ರ
Good afternoon, ma'am. Good evening, ma'am. Can I please share my own screen, ma'am? Can you give me the access, ma'am, to share? Hmm. Access good. Hello, ma'am. Good evening. Can you please give me the access to share my own screen, ma'am?
Yeah, 1 second, we're giving you the.
Thank you. Okay, thank you, ma'am.
System.
Can I start my presentation, ma'am?
Yeah, you will be given a time for 6 minutes and you will get a reminder at the 5th that
Okay,
1 minute
ma'am.
is left. And there will be 2 minutes for the question by the judges.
Okay, ma'am. Okay, ma'am. Thank you. Can I start now, ma'am? I'll start now. So, good evening, everyone. The title of my study is Physical Activity, Anxiety, and Well-being among undergraduate students of Bangalore Medical College and Research Institute during the COVID-19 pandemic. The COVID-19 pandemic has resulted in restriction of many elements in all walks of life, affecting both physical and mental well-being. The World Health Organization recommends at least 150 minutes of moderate physical activity and 75 minutes of rigorous activity or a combination of two per week. Previous studies have shown that 40.5% of the inactive individuals became less active during the COVID-19 pandemic, and the adults who are regularly physically active experienced fewer symptoms of anxiety than their peers. It is likely that prolonged increase in the sedentary behaviors such as spending excessive amounts of time sitting or increase in the screen time among the students. Hence, this study was conducted to assess the physical activity, anxiety, and well-being among the undergraduate students of Bangalore Medical College and Research Institute during the COVID-19 pandemic. Materials and methods is a cross-sectional study conducted in Bangalore Medical College and Research Institute among the undergraduate students from September to October 2020. The sampling method used was universal sampling technique, and ethical clearance for the study was obtained from the Institutional Ethical Committee. Any of the study participants suffering from anxiety disorders and on medications for the same were excluded from the study. A semi-structured questionnaire was used, with physical activity being assessed by the Gordon Leisure Time Questionnaire, anxiety assessed by the Generalized Anxiety Disorder 7-item scale, and well-being, which was assessed by Mental Health Continuum short-form questionnaire. This questionnaire was administered by an online survey using Google Form after taking online consent through the same Google Form. The data was entered in MS Office Excel and the analysis was done using SPSS version 20.0. The study consisted of 147 participants, where the mean age of the participants was 20.53 years with a standard deviation of 1.63 years. Of the study participants, 51% of them were males, and 43% of the study participants belonged to upper middle class of socioeconomic status according to Kuppaswamy scale of classification. The weekly leisure time activity score was 79 with an interquartile range of 36 to 112. The study participants, 83.7% were active according to the categorization by the Gordon scale score, 10.9% were sedentary, while 5.4% were moderately active. You see in the table, there was a significant association between the change in physical activity since COVID-19 to the categorization of the Gordon scale score. Here we see that 52% of the individuals who were active had a decreased physical activity since the beginning of the COVID time. The median of the generalized anxiety 7 with interquartile range ranging from 1 to 11. Of the study participants, 47.6% had minimal anxiety, while 14.3% of the study participants had severe anxiety. There was a significant association between the change in weight during the COVID-19 and the change in physical activity since COVID-19 with the variables with the categorization of the generalized anxiety score scale. Here we see that 85.7% of the individuals who had severe anxiety had decreased amount of physical activity since the beginning of the COVID time, while 71.4% of the individuals who were categorized as severe anxiety had increased weight during the time of COVID-19. 9.8% were moderately mentally active, while 14.3% were categorized as languishing according to the well-being score. But no significant association was found between the variables and the categorization of the well-being score. Even though 62.5% of the individuals who were categorized as languishing had a decreased amount of physical activity during the COVID-19 pandemic. Hereby concluding, the majority, that is 53.1% of the study participants, perceived reduced physical activity during the COVID-19 pandemic. 14.3% of the study participants had severe anxiety, and 59.8% of the study participants were moderately mentally active. It is observed that increase in weight and decrease in physical activity is significantly associated with study participants with higher anxiety levels. Hence, I would recommend more efforts need to be directed towards health promoting measures by increasing the practice of indoor physical activity amidst the restriction, and government should also consider developing some national guidelines to address the psychological distress during and after the COVID-19 pandemic. Opportunity to acknowledge the Dean cum Director of Bangalore Medical College, all the study participants who answered my questionnaire, and all the faculty and postgraduates, Department of Community Medicine, for the support in conducting the study. Thank you.
Thank you for such a nice presentation. Now the questionnaire round. I request the judges to start the questionnaire round.
So, yes, sir, go ahead.
You can ask, sir. Later I will ask.
Yeah, now let us give a chance to the other participants if there are. Let them come with the question first. If they don't have any, we will ask. Any other participants would like to pose any query to Dr. Sarala? Sarala? Okay.
Yes, sir.
No? Okay. Dr. Sarala, congratulations for a good work done.
Thank you, sir.
My first query is,
yes, sir.
The students were at home. Why did you choose them for studying physical activity anxiety, and well-being. What is the reason? What is the novelty in
So
this study?
yes, sir. The reason being same, that the students were all isolated at their home. They were not expected owing to the lockdown period. They were not expected to be any movements outside. So at this moment, and along with the pandemic reasons being, I wanted to see what is their physical activity during the time when they have to be isolated, and what type of physical activity would they want to. Their anxiety, which is owing to the COVID-19 pandemic, sir.
Okay, you said universal sampling. Did you
Yes, sir.
take informed consent?
Yes, sir. So the contained a section of consent before even they could fill out the questionnaire, sir. So only any person who consents for the questionnaire would be taken into the further part of the question, sir. Only person who consents for the study getting the questions, sir.
147 students consented.
Yes, sir.
What was the total class strength or the student strength?
So each class of MBBS has 250 students, sir, in our college. So expecting it would be 1,000, sir. Total would be 1,000, sir. Taking 1 to 4 years of MBBS, sir.
Okay, what are the factors which might have influenced the internal validity of your study? Or what are the confounders that might have influenced your study? Can you go to that statistical significance table, please?
Sir.
Yeah.
Confounders being the physical activity was measured as per their perception, sir. And also the questions like change in physical activity or change in weight during the COVID-19, it was not a measurable, the weights were not measured, so it was according to their perception. So what was their change in physical activity or weight was taken.
Okay,
Taken, sir.
thank you.
Yes, sir. Thank you,
Go
sir.
to Girish, sir.
Good presentation. Like what I feel, he could have, if you had used any comparative, that would have been much good, I think. But you have
Yes,
done
sir.
good study. Yeah, comparison you didn't thought of.
Yes, sir. And if the pre-COVID data was available, it's significant for me to tell that these changes were only because of the during the COVID-19 pandemic and the isolation during the same. But that would be my limitation, sir.
Okay. Okay. Good presentation. Thank you.
Thank you, sir.
So thank you for such a nice presentation. Now coming to the second presenter.
Oh, sorry to interrupt. Organizers, can you tell us the time taken by this presenter? Somebody is keeping time for us, no?
Yeah, so 5 minutes to be exact.
Okay, thank you. Thank you. Thank you, Dr. Saral. Best wishes for you.
Thank you,
best
sir.
wishes to Rangnath, sir.
Thank you,
Convey
sir.
our wishes to Rangnath, sir.
Sure,
Okay.
sir. I'll convey,
Thank you.
sir.
Thank you.
Thank you, sir.
So next we have Dr. Shweta Sanadi. So ma'am, do you want to present yourself or do you want us to share your PPT?
Please allow me to share my screen.
Okay. Yes. Can you present your screen?
Yes, ma'am.
Dr. Shweta, you can start. Yeah, we can't see your PPT yet. Yes, you are audible, but we can't see your PPT yet. Just try to. Yeah, it's fine. You can start with your presentation now.
study during healthcare workers of Chickpet constituency, Bengaluru. This COVID-19 pandemic has led to a huge loss of human life globally, which presented the unprecedented challenge to the public health. The community healthcare workers, being the core part of this public health, are in front line with the highest risk of getting infected and are experiencing a higher work pressures and stress with the various emotional and social impacts. It's not only this, we are very well aware that there are many incidences where, in case of indoor incidents, where our medical team, when they went for a survey, have been stone pelted by the public and brutally harassed by them, which which will not only result in poor physical and mental outcome, but also leads to a lack of motivation, absenteeism, and low morale in the staff. Hence, the data regarding the stress and burnout among the community healthcare workers are very scarce, and hence this study was taken to assess with an objective to assess the stress and burnout among community healthcare workers who are involved in COVID-19 duties of Chickpet constituency, Bengaluru. Coming to the methodology, this was a cross-section study which includes all the UPHCs of Chickpet constituency South Zone, Bengaluru, conducted from September to October. The participants were, the study population was all the community healthcare workers who are involved in COVID-19 duties in that study period. The sample size was 140 based on the previous studies which is conducted by Ruchira W. Kanse et al. In Maharashtra with a prevalence of burnout of 52.8%. It was a simple random sampling method. The assessment tools used were burnout inventory and perceived stress scale 10. After obtaining clearance from Institutional Ethical Committee, data was collected by using online Google Forms through for those who were not able to understand the questionnaires like ASHA workers and Group D workers. The scores with ranges of 0 to 13 was taken as the low stress level, 14 to 25 was taken as moderate level, and 26 to 40 was taken as high perceived stress scores. The scores above 50 for each domain of the burnout was considered as that person is experiencing the burnout. The data was analyzed using descriptive statistic using 20th version SPSS software. Coming to the results, the socio-demographic details says that maximum of my participants were belonging to the age group of less than 30 years with 65% with a mean age of 30.29 plus or minus 7.5 as a standard deviation, and the median was 28 years. Most of them are belonging to the female gender with 54.3%, and most of them were unmarried with 58.6%, and 72.1% of them were belonging to the upper middle class or socioeconomic status of modified Cusomis classification. Coming to the results of distribution of stress among all the participants, it was seen that most of the participants, of 80% of the participants, were experiencing the moderate level stress, and almost equal proportions were experiencing low stress and high persist stress of 10% of them. The mean stress score was 19.77 plus or minus 6.25 as a standard deviation, and median score was 20. Coming to the burnout among participants, it was seen that 31.4% and 32.1% of them were experiencing work-related and pandemic-related respectively, and personal burnout was experienced by 20% of them. The mean burnout score was 43.79 with a standard deviation 0.31 and median was 44.24. With the socio-demographic details with the burnout. After applying chi-square test with the age, gender, relating to the personal, work-related and COVID-19 related burnout, it was seen that age and gender were significantly associated with the work-related burnout with a p-value of 0.001 and 0.012 respectively. Personal job profile, it was seen that it was significantly associated with all the three domains of the burnout, personal, work-related, and COVID-19 related, with a p-value of 0.001, lesser than 0.001. When seen for the association of social demographic details with the stress, the age and gender could not be significantly associated, but the job profile was significantly associated with all the three levels of the stress with a p-value of 0.006. There is a high prevalence of moderate stress with the 80% and pandemic-related burnout, which was 32.1% among the community healthcare workers. The work-related stress was significantly associated with the age and gender and job profile of the participants, and burnout was significantly associated with the job profile of the participants. After this, I would like to conclude that Targeted interventions are required to ensure their mental well-being and enhance their productivity. I would also recommend that continuous motivation and also considering their efforts during the pandemic is necessary by the organization levels to ensure their mental well-being for a longer period of time. After doing this study, I would like to acknowledge our Dean and Director for giving me the opportunity. I would like to thank our MOH, Dr. Devika Rani of Chickpet Constituency South Zone BB, permitting me to do this study, and also thank my guide, Dr. Rangana TS, HOD and Professor of this department. I thank all my PGs and my participants for giving me the time to conduct this study. These are my references. Thank you.
Thank you, ma'am, for such a nice presentation. Now I request judges for the questionnaire round.
So any other participants have any questions can ask the presenter. Any questions? Manjunath sir, you can initiate, sir.
Yes, sir. Thank you. Dr. Sanadi.
Yes, sir.
Good
Yes,
work.
sir. Thank you,
Congratulations.
sir.
What was the total sample size?
140, sir.
Okay. Simple random sampling you told. What could be the total number of workforce, community workers?
It was not accurately found out, sir, because here, sir, also for the screening duties. So approximately it was including all the permanent job holders. It was 180 plus or minus 10 or 20, sir.
Having the complete framework without a list, how did you do simple random sampling?
Yes, sir. Yes, sir. Those who were involved in the COVID-19 duties were only 180 of them, sir. We had the duty rosters. With that, I calculated for all the 7 UPS, it was 180. But exact number of persons who are actually involved in this thing during that period was not available, sir.
Okay.
The thing is, like, it was again, the pandemic is totally, we have taken like how they used to manage.
Managing.
See, stress. Yeah, this is because COVID-19 pandemic itself is like a sudden slash on the community, is it? So
Yes, sir. Yes, sir.
from the government to the doctors to everyone is burned out, is stressed. But
Yes, sir.
as the doctors, as health workers, we need to work because we'll be the frontline workers. So
Yes, sir.
yeah,
Definitely.
yes, there is definitely burnout, but and even we have seen, like we have seen in the media or in the reports, many deaths are also have occurred. Okay,
Yes.
so many deaths have occurred, many have gone to depression, many things. Even it could be in health workers. So this you are mentioned. Any, like, you could have just added like how they came out or what they used to do. Is it
Yes,
like
sir.
that?
That would have added more point to my study, sir. By doing the qualitative study also, as there was no time for the people who are doing that work, who are involved in that work, they were not giving the time. I planned to do the qualitative study also, but they were not free to give time for me to collect the data. That's why I just taken online survey plus the personal interview, sir.
Okay. Yeah, that is one thing, madam. Like, one more thing is, did you discuss with your like whoever is putting the duty roster authorities so that you need to be adjusted at least something what better
Yes,
can
sir.
be
Definitely,
done?
sir. Definitely, sir. I talked to the MOH, I talked to the medical officers also that the rotation basis should be there with four teams or 3 teams, and also they have to recruit for more ASHA workers and ANMs and other volunteers, and giving attractive salaries for them.
Yeah, one more thing is, this is a whatever the immediate actions, the any action will have immediate, moderate term and the long term, is it? See, as a pandemic, we have to think of you have done a study, you have come out with report, and that need to be discussed immediately. What best can be done? So that need to be discussed and to be done. So not just with getting the like everyone is burn out and just telling it should not be stopped. Okay. Yeah.
Definitely,
Good
sir.
presentation.
We had a meeting regarding that with the
Okay.
MO.
Good presentation. Thank you.
Thank you, sir. Thank you, sir.
Okay, Dr. Sanadi, continuing with the Copenhagen inventory
Yes,
for
sir. Yes, sir.
burnout. It is an interesting thing that you have used that scale.
Oh, yes,
Is
sir.
it validated for Indian population is the question.
Yes, sir. Yes, sir. Indian population, it was validated. That was
Where
also
is the
validated.
reference?
Reference
Do you
is
have
from
the
the.
reference?
Yes, sir. Can I share that, sir?
Yeah, please show the reference. If it is there, otherwise don't worry.
The document also, if you want, sir.
No problem.
Fourth reference, sir. Copenhagen Burnout Inventory.
References, last slide.
Yes, sir. I have shared, sir. I think it has taken a little more time. I have shared my.
Number 4.
Yes, sir.
You have shared the reference, but
Yes.
this is the actual original inventory, not the validated study. Okay, don't worry. Don't worry.
Validated, sir. Only the.
No problem. Don't. I know that it is validated. That is
Yes,
why
sir.
I'm
Yes,
asking
it
you.
is validated.
I'm asking
Recently, it
you.
was done during the COVID-19 this thing only. It was done for the
No,
COVID-19.
it was done before only. Don't worry. Another important thing I like is you said qualitative study.
Yes, sir.
And you have also mentioned you did Google Forum survey.
Yes, sir. Yes, sir.
And your study population are ASHA workers and frontline health workers.
Yes,
Were
sir.
they
Definitely.
comfortable filling up Google Forms?
So those who were little bit okay with the, using the Google Forms, I have shared the Google Forms through WhatsApp. For those who were not able to read it and understand the questionnaires, I have done the personal interview, sir, which have been.
You have mentioned also. I saw it.
Yes, sir.
Good.
Yes, sir. Yes.
Okay. Now you have mentioned the recommendation as targeted intervention. Who should do that? Who should do that?
The organization level personnel, sir, authorities.
Please remember one thing. When we do a study and find that there is a problem in the population, study population, it is our duty ethically to initiate some intervention. Kindly look into that. Okay. Thank you for a good presentation.
Okay.
Anybody else has anything, please go ahead. Otherwise, I am done. Thank you.
Thank you, sir. Thank you so much.
Thank you, Dr. Shweta. Next up, we have Dr. Pratap Pawar. Sir, do you want us to present your presentation or are you going to present yourself? One second, sir. Yes, sir, you're audible. So you can. We made you the presenter. Now you can share your screen.
Okay. The content.
He's the presenter right now.
Can someone mute and audible or not? Unmute.
Hello. Yeah. Can you hear me, madam?
Yes, sir.
Yeah. Can you allow me to share the screen? There was network issue from my end. Now it is fine. Hello. Hello. Can you hear me, madam? Can you please allow me to share the screen from my side? Okay. Am I audible to everyone?
Yes, sir, you are.
Okay. Can I go ahead with the presentation?
Please share your screen.
Okay. Good evening, everyone. The study that I'll be presenting today is assessment of lifestyle changes
Excuse me,
among
sir.
informed.
Sir, we can't see your screen. You have to share your screen first.
Actually, I have shared the screen.
No, no. We can't see, sir.
Just a moment. Sorry for the inconvenience.
Sir, do you want us to share your presentation? If you haven't made any changes, we can share and you can present simply.
Yeah, I think that is better.
We give you the mouse control.
Okay. Uh,
You can go for the next presenter at least. I think Neha D'Souza. She can present so that once the Dr. Pratap gets rectified, we can continue. I think so. That can be done, sir. Manjunath, sir.
I think that is better.
Dr. Neha, are you ready?
Yes, I can present. Can you give me the access to share my screen?
Yeah, sure.
Dr. Pratap, see to that your connection is better so that next time also it should not be same. Okay, please have a better connectivity so that next after Dr. Neha D'Souza you can present.
Am I audible and is the screen visible?
Sure.
Yes, you're audible and we can see your screen. Okay. Can I start now?
Yes, please.
Okay. Good evening. The title of my study is COVID-19 Positive Patient Satisfaction with Quality of COVID Care and Factors Influencing It in Victoria Hospital, Bengaluru, a mixed method study. The pandemic has brought with it to patient care and measuring the quality of care is essential in both in times of stability and in times of crisis, especially in times of crisis when there is rapid change in treatment modalities and protocol of care. Patient-centric approach is a very important care and is associated with increased healthcare utilization and health outcomes. It has been where the COVID-19 pandemic, where the isolation patients less frequently than non-isolated patients. Therefore, this study was conducted to assess the patient satisfaction with quality of COVID care and factors that influence the satisfaction in Victoria Hospital, Bengaluru. It was a mixed method study conducted in Victoria Hospital on COVID-19 patients admitted in the month of November. Sample size 99 based on a pilot study with absolute precision of 9% and where 80% of the participants were satisfied with care. Sampling technique was simple random
Dr.
sampling
D'Souza.
and patients were willing to give. Yes, sir.
Sorry for interrupting. Move your slides also. It is stuck in number 2 only.
Is it come to materials and methods now?
Now it is visible.
Oh.
From objectives you go back. Previous slide. Yes,
Can
please.
I restart?
Continue. We can see.
So the objective was to assess the patient satisfaction with the quality of COVID care in Victoria Hospital and to determine the factors which influence satisfaction with COVID care. Study design was a mixed method study in Victoria Hospital, Bengaluru, on COVID patients admitted in the month of November. Sample size was calculated to be 79 based on a pilot study conducted where 80% of the patients were satisfied with care with absolute precision of 9%. Sampling technique was simple random sampling. Inclusion criteria was patients willing to give consent, age more than 18 years and tested positive for COVID-19. Patients not willing to give consent and admitted in ICU and death patients were not included in the study. Telephonically by interview method with a pre-tested semi-structured questionnaire using the hospital consumer assessment of healthcare providers and system survey tool, and data was then analyzed using SPSS version 20. 20 participants willing for in-depth interview were then selected and telephonically interviewed for 15 minutes in their local language, and the call was recorded. Verbatim was then analyzed using Atlas T9 software. 41.80% of the patients were belonged to the age group between 20 to 39 years, and again 41.80 belonged to age group of 40 to 59 years, where the mean age was 43.75 plus or minus 15.19. Median was 41. Male, 73.10% of the participants were male, and 44.30 belonged to the lower middle class of socioeconomic status. 55.70% of the patients were BPL card holders, and only 38% were asymptomatic. The rest of the patients were symptomatic. 70.90% of the patients had comorbidities. In terms of frequency of response in each dimension of care, in nursing care, physician care, hospital environment, and discharge, more frequently positive responses were seen with 40.17% in nursing care, 46% in physician care, 45.55% in terms of medication. On majorly negative response was seen as 46.05, and after discharge, middle level responses of 81.21, and in food, majorly middle level responses of 46.70% were seen. When the patients were asked to score the hospital between 0 to 10, 46.80% of the patients gave a high rating to the hospital. Was then checked for association with any of overall hospital rating, with BPL card, significant relationship formed between duration of hospital stay and overall hospital rating. When hospital rating was then seen for association with each dimension of care, significant relationship was found between nursing care, hospital related. Post hoc test was conducted to see the in-group significance in relationship. In hospital environment, significant statistical significance was seen between middle level and high and low in food. There was low and middle and high and low. Discharge was high and low. For factors influencing were drinking water, food, medication, cleanliness, and communication. Factors affecting drinking water were no hot water and limited water supply, bland taste and irregular timing for food. Factors influencing were changing food handlers, and medication. Factors affecting was no tablets given at the time of discharge, clean bathroom. Factors influencing was daily cleaning. Factors affecting communication was decreased communication. So, there was, when compared with between quantitative. In qualitative and quantitative data, they see comparisons between the significant data.
We can ask the judge for the questionnaire. Maybe in between that, you can share that.
No, you just conclude. Go to the conclusion slide and conclude.
Yeah. So, for positive responses, we see most frequently in nursing care, hospital environment, discharge, and dimensions of care. And qualitative and quantitative findings were similar in regard to hospital environment, food, and perception regarding the quality of care. My suggestion is that there should be a regular feedback system with narrative reviews from patients to Thank you.
So now we request the judges for the questionnaire round.
Hello, Dr. D'Souza.
Yes.
Congratulations for a good presentation. You used a mixed method, no? Qualitative and quantitative method. And the interview was through. How did you collect the data?
Clinically interviewed, sir.
Okay, inclusion
had
criteria.
A list of patients.
Okay. How did you
They were admitted in November? Was there, sir? There 190 patients were admitted in the month of November. I procured the list, and phone numbers were there in that list. And then I contacted the patient and got consent from them. Then the survey was conducted. Out of 190, by simple random sampling, I selected 79.
How much?
79, sir.
Okay, that you explained also. Okay, 17. You have used qualitative software. What was the software? Atlas T. Atlas T9. Who did the analysis using Atlas T? You only did, or you started?
Sir, with the help of my senior, sir.
Okay. No more questions. Over to Girish, sir.
Right. It was a nice presentation, Dr. Neha D'Souza. So, like mixed method, like what are the difficulties you faced actually during the any because so much time they were giving, so all those difficulties during
main,
this see, because quantitative study is like a focus group and all, it's a one-to-one, it will be more effective, or even okay telephone, but it a lot of time is required, as you mentioned 15 minutes. Is that it was everyone gave any problems what you faced?
so that was and then to get responses from. So it was structured interview where I had planned, and after that, based on what the patients gave, I took the interview ahead. But it was time consuming, and to build a rapport, it was
I think your voice is breaking, madam. Voice is breaking, not audible, I think. You can
now,
repeat.
sir.
Yeah, not, you are now audible. Please repeat.
Ma'am, you can switch off your camera.
Okay. You hear me now, sir?
Yeah, it can be heard now.
Difficult to develop rapport with the patients because it was a one-time interview and it was also time-consuming. So that was the difficulty I faced, and I had to because most of the patients were not very handy with their devices, could not send any questionnaire to them. So I had to conduct the survey also telephonically. It was a little time-consuming, sir.
Good. Anyhow, with you so many difficulties you have done. So good. Even you yourself you have used this software and all as a PG. Those good learnings definitely. And again, especially as a new disease, the qualitative studies many a time require. And even what's the time when you actually did this? What time? When you did? In the November, huh? November. Okay. Yeah, even if it has done little bit earlier also, it would have been much better because in depth, like whatever the problems would have been much easily known. Good presentation. We can continue for the next.
Thank you, sir. The host. It was a time where there was a problem and the technical error also counted for my time.
Yes, so we counted the technical error. It was a total of 7 minutes, 45 seconds. So with the technical errors.
Oh, cannot be deducted?
Yeah, we are going to 7 minutes, I think, should be considered.
Dr. Neha, don't worry. Don't worry about the time. There's very little marks for that. Huh?
Thank you.
Don't worry, and we'll
Okay,
we'll account for the time lost due to technical snack. Okay. No worries,
Okay.
please.
Okay, thank you, sir.
Let us go ahead.
Next up, we have last presenter, Dr. Shweta Paul. Sir, will share your presentation.
We can't hear you, sir. You have
Dr.
to.
Pratap,
For the host, please yourself share because many of them don't have a better connectivity. I think better I request you only to share if they are not changed and all. That will be better.
Okay,
yes.
sir.
You're muted.
Can you please give me the permission to share the screen? Now I have quality than better one than last time I had. Okay, madam, can you give me the permission? Okay, thank you. Yeah, thank you. Presentation visible?
Visible. Your time starts.
Okay. Okay. Good evening, everyone. Today, I'm going to present a study conducted on assessment of lifestyle changes among information technology professionals during COVID-19 using a multidimensional scale, a cross-sectional study. Role in pathogenesis of several non-communicable diseases like coronary heart diseases, diabetes, hypertension, and several mental disorders. And healthy lifestyle habits are vital for maintaining an individual's physical and mental health. The rapid spread of COVID-19 virus to nearly all parts of the country has posed an enormous health, economic, environmental, and social challenges. Hence, this study evaluates whether lifestyle behaviors have changed among IT professionals under home isolation during COVID-19 pandemic. The objective of the study is to assess the lifestyle habits among IT professionals during COVID-19 pandemic and also to determine the factors associated with lifestyle changes among IT professionals during COVID-19 pandemic. Where it is a cross-sectional study conducted in Bengaluru among IT professionals, and it was conducted from a study period of September to October 2020. The sampling method used was snowball sampling method, and based on the pilot study conducted, the mean SMILE score was 124.07 with standard deviation of 13.21, and with the expected difference mean of 3, the sample size was calculated to be 75. Among IT professionals, a semi-structured questionnaire was used to collect socio-demographic details and validated schedule called SMILE, that is short multidimensional inventory lifestyle evaluation. Scale was used to assess lifestyle habits under the following domains, that is diet and nutrition, substance use, physical activity, stress management, sleep, social support, environment exposure. Data collected was analyzed using SPSS version 20.0. Descriptive statistics such as mean and standard deviations for continuous variables and frequencies for categorical variables were used for getting to result, and independent student t-test was used to check association. To results, the socio-demographic details were mean age of participants was 30.29 with a standard deviation of 6 years. 70.7% of the participants were male. 61.3% participants were unmarried, and 38.7% were married. 85.3% were Hindus, 12% were Christian, and 2.7% were Muslim. 22 participants were reported to be self-isolated. 5 with COVID-19, and 10.7% lost somebody, that is closed family circle people or the friends due to COVID-19. Out of 75 participants, 2 participants reported to have lost their job during pandemic, and total the mean SMILE score among the participant was found to be 127.2 with standard deviation of 16.8. The table depicting association between gender and lifestyle habits. The total score is not with the association. When student T test was applied, the P value was not significant. And in the individual domains, physical activity and stress management, there was a significant difference between male and female with a p value of less than with a significant p value in physical activity and stress management. where male had a better or healthier lifestyle compared to females. This table, this depicts the association between marital status and lifestyle habits. In this, I have depicted only which have significant association, and I have omitted which are not significant ones. So total score, where married people have 133.4 mean smile score, have better or healthier lifestyle compared to unmarried people. And there is also a significant difference in social support and diet and nutrition among married than in unmarried participants. There is association between self-isolation and
1 minute
lifestyle
is
habits.
left.
Among the self-isolation, among physical activity, among the people who were self-isolated, the physical activity was better, or they had healthier lifestyle. And among those who were self-isolated, there was negative health lifestyle. And an association between COVID-19 infection and lifestyle habits. Those who were positive for COVID-19 infection, they had substance use, and they had less lesser score, which means they had unhealthy lifestyle habits. To conclude this, in the study, the participants reported changes in lifestyle habits in different domains, which are significantly associated with gender, marital status, positive for COVID-19 infection, and self-isolation during the COVID-19 pandemic. This can be related to the restrictions imposed by the government for the general population, where people can't go from their home freely, or because of the anxiety about the COVID they have, and there may be the factors. And these findings can further help to devise lifestyle guidelines among IT professionals during any public health emergency in the future. Thank you.
Okay. Dr. Pawal?
Yes, sir.
Done.
Thank you,
I have
sir.
two questions for you. Did you look at the pre-COVID lifestyle of the IT professionals? First question.
No, sir.
Okay, you can answer.
Yes, sir. No, sir. Do any study on IT professionals, sir. If I had the data on that, I would have had a better results to compare with, sir.
Could we have collected the data pre-COVID information from the patients?
Yes, sir, I could have
This
collected,
study.
sir, but yes, sir, I could have collected, but I felt maybe there would be information bias in this, sir, like lack of or recall bias in this, and so I thought not to include that, sir.
Oh, bias, systematic error. Okay.
Yes. And this questionnaire had 43 questions in self, sir, the smile score scale.
Score.
So because of that, maybe they would have respondent fatigue. So because of that, I completely try to concentrate on
No problem.
COVID time.
No problem. Second question is,
Yes,
you
sir.
were constantly using the word association,
Yes,
gender,
sir.
marital status, etc. Even in the conclusion, you have used the word associated with gender.
Yes, sir.
So, what is the statistical test you are using? T-test, huh?
Sir, student
T-test.
test I used, sir.
Okay. Can you tell us a better statistical model to analyze the data and also use the word association? Last question.
Chi-square test can be used, sir.
Okay. Thank you. Over to Girish, sir.
Yes, sir.
Yeah, good presentation, Dr. Pratap.
Thank you, sir.
Did you? It's a cross-sectional you did, is it? You could have followed up. No, anyhow, this was a online one like you are doing. You could have followed up. That would have been a much better. See, you have used like there was restriction from the government and all. See, and you have mentioned maybe 2 months. Is it? Your the study duration.
1 month, sir.
1 month. Like
Yes, sir.
okay.
September to October.
Yeah, because maybe you could have followed up because maybe with every unlock it was coming, is it? Unlock how the things used to change and that and all you could have assessed. So that would have been much improvement.
To follow up, thing is, I did not have the contact details, sir. Not everyone expressed to share their contact details with me because I had kept it optional so that they can freely answer the questions so that they won't have any like they did not feel and not feeling to share the questions or with us. So to keep it, I just asked them to kept it optional, sir.
Then how did you interact then?
I had a questionnaire. I'd send it through Google Forms, sir. So after taking consent only, then they proceeded to answer the questions, sir.
Yeah, that. But you had the contact numbers, no?
Sir, this is a snowball, sir. Like I had like few people where I had my friends. Among them, I asked if they had any IT professionals.
Okay.
And then further on, it was shared among their colleagues, sir.
Okay, okay. That way. Okay. So then it is difficult. Okay then.
Yes,
Okay. We can continue with the next presentation.
Okay. Thank you, sir.
Thank you, Dr. Pawar. So he was the last presenter. We had one more presenter, Dr. Sharaf, but he hasn't reported. I wanted to inform the judges about Dr. Sharaf. He hasn't reported. So with this,
You
we
can
have
contact him. Contacted, madam. You can just contact
yes,
them.
we tried, but we couldn't get any response. So yeah, he's not here.
Okay, okay. No, this was an online. No, wherever are there, they could have presented. So he
Yes,
is
sir.
from Bangalore Medical College. We can ask for PGs at least the other ones. If you can 1 or 2 minutes, you can wait if he is present.
We request all the presenters and judges to stay there because we are going to have a group picture. We are just waiting 1 more minute for Dr. Sharaf. So we request all the candidates and judges to switch on the camera. We are still waiting for Sharath, but till then we can click some group pictures.
Your views on this. We are waiting for Dr. Sharaf. I tried calling Dr. Sharaf. He's not picking up. So we would like to wind up because we have to on would wind up and the judges can forward the checklist through mail. And thank you all the participants for your patience and good presentations. Continue the good work and judges. A very important role you have played in our session. That is, during a valuable time is being given to all of us. Thank you all.
Okay, thank you, organizers. Thank you, Girish sir. Best wishes to all the participants. Take care. Bye.
Thank you.
Thank you
Very much,
so
sir.
much. It was a nice presentation. It is a different
Thank you, organizers.
online presentation as with the regular one, definitely, but there is no other option to put. I thank for giving me an opportunity. And also, I participants imagine even as a created previous time, even get the burnout, but you now get your work. So, all of
Thank you, sir.